discussing liver and biliary tract pathology. Let's start first with the liver. Looking at the normal liver, you see here that it weighs about 1,400 to 1,600. If you go below this one, way below, then you have a state of atrophy. And this is commonly observed in cases of cirrhosis, liver cirrhosis. When you go beyond 1,600, then you are in the state of hepatomegaly. You get the enlarged liver, heavy liver, secondary to certain disease process. Okay, the liver has dual supply. It has the portal vein and the hepatic artery, and it also has this portal tract, which is composed of three structures: the portal vein, the hepatic artery, and the bile duct. Looking at a single hepatic lobule, this is a schematic diagram of a normal hepatic lobule. The central area is occupied by the central vein, and then radiating from it are the three zones. We have the zone 1, which is nearest the blood supply. Next to it is the zone 2, and then the farthest zone from the blood supply is the zone 3. So you would expect if there is derangement in the vascular supply, this area, the zone 3 area, is the one that is first affected. Seen on three corners of the hepatic lobules are the portal tracts. As we have mentioned a while ago, it is composed of these three structures. Looking at a closer view of the liver, you get to see the different structures, normal structures that are part of this. We have the sinusoids, okay? If we go back here, these are the areas of the sinusoid. This is in between the cords of hepatic cells. So a closer view of that would show us the sinusoidal area. And this is lined by endothelial cells, as you can see here. And this particular space, this is what we call the space of DC. And in there, you get to see the presence of the stellate cells. We also have the resident macrophage, which is called Kupffer cell. And then these are the liver cells, as you can see. In between them are the bile canediculi, which drains into the canal of Hering, eventually into the bile ductules, and then into the terminal bile ducts. Okay, let's look into the mechanisms of injury and repair in the liver. It can be reversible, just like in the form of steatosis or fatty change, okay? Or in the presence of bile cholestasis. If you get rid of what is causing them, then it reverts back to normal. The function of the liver, the morphology of the liver will revert back to normal. There are instances that it is irreversible. If there is necrosis and there is destruction of the parenchyma, then it becomes irreversible. Apoptosis, the presence of the programmed cell death, of course, this is the dead cells are no longer are reversed into the normal state. Apoptotic hepatocytes are also known as councilman bodies, as the one who discovered them is named Councilman. So he named this after his name, of course, and this is specifically, if I remember it right, utilized for the effects of yellow fever. And then on other diseases, we get to see apoptotic hepatocytes as well. And they commonly call it acidophil bodies. Okay, with regards to necrosis, it can be confluent and it can be widespread, affecting large area of the liver, or it can be a bridging necrosis that forms links from one area to another, just like um, presence of a necrosis from the central vein towards the portal tract, or from portal tract to another portal tract of another hepatic lobule or of the same hepatic lobule. With regards to regeneration, no, the liver cells can actually replicate by mitosis. No, so if there is remaining normal liver cells, they have the capability to replicate on themselves. There are instances that it makes use of primary intrahepatic stem cell niches, not just like in other areas of the body. Okay, so that those are the ways on how to regenerate the liver cells. Scar formation and regression. So this also occurs in the liver. So if um, if an injury happens in the liver, then there is a possibility that scar can be formed, and this is the responsibility of the hepatic stellate cells. They're the ones that are responsible for the formation of the scar. It is converted to a highly fibrogenic myofibroblast, and there are several factors involved in the process. Of course, presence of chronic inflammation, the release of inflammatory mediators, cytokines, and chemokines, the presence of toxins, and the presence of extracellular matrix disruption. If there is cessation of the stimulus that's causing the problem, and as well as the presence of metalloproteinases, then regression happens. Okay, with regards to inflammation and immunity, there is involvement of both the innate and the adaptive immunity in liver pathology. Okay, let's look specifically at liver failure. This is the most severe clinical consequence, of course. No, it can be an acute liver failure, and we will discuss that, as well as chronic liver failure. Regarding acute liver failure, this is associated clinically with encephalopathy. So there are changes, no, secondary to the involvement of the nervous system, and would lead to manifestations, no, that is attributed to encephalopathy as well as coagulopathy. So derangement in the clotting system of an individual, because we all know that liver is a primary source of proteins, particularly the coagulation factors. So this occurs within 26 weeks of initial liver injury. And it says here that there is absence of pre-existing liver disease. They also call it fulminant liver failure. Morphologically, we get to observe the presence of massive hepatic necrosis. The liver can be recognized as having this morphology, gross morphology. It is small and shrunken, and the microscopic morphology, of course, would depend on the nature as well as the duration of the insult. So we can see diffuse microvesicular steatosis or fatty change, which can be related to pregnancy, fatty liver, and also idiosyncratic reactions to certain toxins that the individual is exposed to. Clinically, the patient would be presenting with the following, nausea, vomiting, and jaundice. Of course, as we have mentioned, derangement in the nervous system in the form of encephalopathy, coagulation defects, and patients will be manifesting as well with portal hypertension and hepatorenal syndrome. Even the kidneys, will have manifestation because of the liver condition. On the other hand, with regards to chronic liver failure and cirrhosis, chronic liver failure is commonly associated with cirrhosis. There are other causes of chronic liver failure, but the most common one is cirrhosis. Cirrhosis occurs diffusely and what we can see microscopically, are regenerating hepatocytes, the presence of dense scar from one place to another, as well as vascular shunting, which can be observed even grossly. So in cirrhosis, it says here that there is a possibility, but it's quite rare that regression can happen. No, the outcome of this would be, of course, the yellowish discoloration of the skin of the patient, the form of jaundice. There is coagulopathy, there is encephalopathy, and of course, because of derangement in coagulation factors, bleeding ensues. Patient is prone to having bacterial infection. Why? Because, as we have mentioned earlier, the liver is a primary source of proteins, and antibodies are in the form of proteins. They need proteins, Patient will be manifesting with pruritus because of the bilirubin, the breakdown of the red blood cells or the uh, build up of bilirubin can lead to pruritus as seen in the patient. Hyperestrogenemia is another thing that is observed. So there is palmar erythema, as you can see here. This is an example of that. If you are dealing with male patient, of course, they're going to have hypogonadism and gynecomastia. With regards to portal hypertension, there are several causes of this, prehepatic wise. Okay, as you can see in the table that is found in your book, if there is obstruction with thrombosis of the portal vein, this can happen. And structural abnormalities, like narrowing the portal vein, those are prehepatic causes. And then we have here intrahepatic cause, and one of them is cirrhosis. Post-hepatic causes, we have several of them listed here, and this can cause portal hypertension in our patients. Okay, so what are the consequences of portal hypertension? Patient will be manifesting with ascites. There is buildup of fluid in the abdominal cavity, and this can be demonstrated by doing certain physical examination maneuvers, to give us an idea that the patient is having excessive fluid buildup in the abdominal cavity, and we call that ascites. There is also presence of portosystemic venous shunting. As you can see here, there is congestive splenomegaly, and then hepatic encephalopathy, of course. And this can lead to uh, trapping of blood cellular elements, leading to thrombocytopenia or even pancytopenia if everything is being trapped, and that causes enlargement of the spleen. Additional syndromes in chronic liver failure, hepatopulmonary syndrome, there is now involvement of the lungs. Patient will be manifesting with hypoxia and dyspnea, difficulty of breathing. There can also be portopulmonary hypertension. So in here, there is pulmonary arterial hypertension and portal hypertension. Patient will be manifesting with dyspnea on exertion, and there is also clubbing of the fingers, just like in congestive heart failure. There is also a state known as acute on chronic liver failure. So in here, there is acute liver failure on individuals with stable, well-compensated chronic liver disease. So the patient already have a chronic liver disease, but he's okay, and then suddenly he goes into an acute liver failure. So that is what you call acute on chronic liver failure. Let's look at infectious disorders involving the liver. Of course, with this, we all know about hepatitis, no viral hepatitis, and there are several of that. Okay, so we have this different hepatitis, classified or differentiated from each others depending on the type of virus these are, no, what viral family they belong to, no, what is the route of transmission, and then we have the other um, characteristics as mentioned here. So go over this table, but we will be discussing these different types of hepatitis individually. Let's first begin with hepatitis A. It usually is a benign process and it's self-limited. Okay, so relatively um, better, of course, than the other hepatitis. The incubation period takes about 2 to 6 weeks. There is no known chronic hepatitis nor carrier state, so it's the individual who only have that particular disease process. No, he will not develop into uh, having chronic hepatitis or will be in the state of carrier, as a carrier. So once okay, they're going to be okay. So uncommon acute hepatic failure as well. Okay. So these are small non-envelope positive strands. So we have here, it's an RNA picornal virus belonging to the hepatovirus, and this can cause transient viremia. Okay, so this is the diagram that shows us the progression or the course of the disease. Okay, so in 2 to 6 weeks time incubation period, then there's going to be serologic markers that will be demonstrated, no, as you can see here. And then we have the acute disease period wherein patient will be manifesting with jaundice, certain additional symptoms, the nausea, for example, or abdominal pain, and then eventually in this period, the convalescent and recovery period, there's also increasing amount of the antibodies that are formed, for the total anti-HAV antibodies, and then we have here the IgM, which are the antibodies that are noted at the beginning of the disease process, and they wane eventually. Okay, let's go to hepatitis B. So this is a 42 nanometer size virus, so spherical, double layered. It's known as the Dane particle. It has a 28 nanometer, slightly hexagonal core, and this is classified as a double-stranded circular DNA. And this is just part of which. Okay, there are 4 reading frames for hepatitis B. We have the nucleocapsid core protein, or the HBC antigen. We also have the HBE antigen, which are used as determinant of hepatitis B serologically. We have the envelope glycoproteins, the HBS antigen. So we also determine this serologically. They have this enzyme, the polymerase. Now it has DNA polymerase and reverse transcriptase activities. And we have the HBX protein, This is responsible for the virus replication, and it is found out to be associated with um, the risk for hepatocellular carcinoma. Okay. So again, this is the clinical spectrum of hepatitis B. This is the period of incubation. Then we have certain um, increase in the liver enzymes during the disease process. And there is the rise and fall of the serologic markers. No, as we have mentioned a while ago, we have the HBs antigen, can determine HBV DNA specifically. We have the HBe antigen and the different antibodies that are formed. No, this period is the convalescence and recovery period. It can occur in weeks to years, no, depending on the other profiles of the patient. No? So we have, of course, the IgM anti-HBC, which we can detect early on. We have the anti-HBe and anti-HBs antibodies. Okay, so there are instances that patient does not completely recover from hepatitis B infection. So what happens there? There is sustained presence of certain serologic markers like this one's listed here. They're positive still for HBs antigen, HBa antigen, and the presence of this DNA particle being detected. So IgM will be produced in wanes, afterwards. Okay, and then of course the transaminases are observed still because of the chronicity of the disease. There are instances that in certain patients, meron silang mga mutated strains, and these mutated strains do not produce HBe antigen. So that would affect now the serologic profile of the patient. So may instances na hindi na-detect ang HBe antigen because it is the mutant strain that do not produce this one. However, they are still competent to replicate, and they have HBC antigen. So you might get a serologic profile na positive to, but you don't have demonstration of HBe antigen. Think that these are cases of the mutant strains or the mutated strains. So the host immune response would determine the outcome. Okay, so if a person has a good immune response, will be able to control this. The function of this is to target cells that are infected with hepatitis B. Okay, there is involvement of particularly CD4 positive and CD8 positive T cells. And another factor is the age. It is said to be the best predictor of chronicity. If you get to see this in a younger individual, then there is a higher probability of chronicity. The difficulty to cure chronic hepatitis B is because they have that ability to insert itself in the host DNA. So it can infect a lot of liver cells. I'll go back to the reason why hepatitis in general would like to targets the liver cell. If you remember the presence of tissue tropism. So tropism is the factor that leads to the attachment or uh, the characteristics of hepatitis B that they wanted to invade liver cells because of favorable environment, like the presence of receptors or other factors that favors the growth of hepatitis B as well as the entry of hepatitis B into the liver cells. The goal of treatment is to slow down the progression of the disease, okay, and to reduce liver damage and eventually to prevent cirrhosis. This particular infection or disease process, no, can be prevented by vaccination process. The third one is hepatitis C. It is a flaviviridae. It is small, it is enveloped, and it is a single-stranded RNA virus. It has one open reading frame. It has this low fidelity polymerase, so this is highly specific. It is unstable with multiple genotypes and subtypes. Okay, so it is known as squashy species. The antibody in the form of IgG, because sabi natin pag IgG, somehow it's protective. However, in hepatitis C, that's not the case. No, IgG does not confer effective immunity in patients infected with hepatitis C. Persistent infection and chronic hepatitis is the hallmark of this disease. It evades host antiviral immunity, so it escapes, okay, the antiviral activity of the immune system. This is associated with certain metabolic syndromes like insulin resistance and non-alcoholic fatty liver disease. So this is the clinical and serology profile that we observe in hepatitis C. No, there is a possibility for recovery, okay, as stated here, but mostly we have this one. No, so the chronicity of the disease, persistence of the presence of the RNA virus in the patient. Okay. The fourth one is hepatitis D. So hepatitis D is known as delta agent. It's a single-stranded RNA virus. The replication is directed by host RNA polymerase. So parang parasitism talaga na they're using the machinery of the host cells. Okay, so this one is dependent on hepatitis B virus. No? So in the form of co-infection, they always have to be with hepatitis B or super infection. Okay. Then we have the hepatitis E. No? Just like hepatitis A, they don't have chronic liver disease nor persistent viremia. The incubation period takes about 4 to 5 weeks rather. Okay. And this one is an enveloped virus, positive stranded. Okay. So this is enterically transmitted, waterborne, just like hepatitis A. You get to see this more commonly in young, middle-aged adults. And if pregnant women are affected, it is incurring risk for high mortality, no, in this population. What are the clinical pathologic symptoms that we see in viral hepatitis? They can lead to an acute asymptomatic infection with recovery, which is good, of course, or it can be acute symptomatic, no, patient manifests, no, but still with recovery, they can be having icteria or not having it. The third one is a chronic hepatitis, can be with cirrhosis or without cirrhosis. That could be another scenario. The fourth is the presence of acute liver failure with massive to submassive hepatic necrosis And the last one, they can have a carrier state. When we say carrier state, the individual harbors the virus and they can transmit the organism, but they don't have manifestation. There are actually two populations of this. One with no liver disease, no? That's one population. And the other population is that those with asymptomatic but have this non-progressive liver damage. So they are the ones who are in the carrier's state. Okay, there is no correlation with HIV and chronic viral hepatitis. So this is seen to be a common clinical problem in patients, no, in having both HIV and chronic viral hepatitis. Morphology wise, if you look at the liver having hepatitis, viral hepatitis, no, we get to see in acute viral hepatitis, the liver is can have normal size or it might be small. No? Microscopically, there is presence of lymphoplasmacytic infiltration. There could be minimal or absent portal inflammation in the portal area or portal tract region. No? There can be a spotty necrosis or can be a lobular hepatitis. Okay, special mention specifically for hepatitis A, they are found to be rich in plasma cells. So for us pathologists, if we look at the liver biopsy microscopically, then we get to see a lot of plasma cell. That would give us an idea that most probably the patient is having hepatitis A infection. Okay, so this is a schematic diagram showing us the different features of acute hepatitis. So there is scant mononuclear infiltration in the portal tract. Okay, we get to observe ballooning degeneration, enlargement of the hepatocytes. There is aggregation of macrophages. We can see presence of apoptosis as well as cholestasis. We get to see bile, no, uh, in the biopsy specimen. On the other hand, the morphology of chronic viral hepatitis includes the following. Presence of mononuclear portal infiltration, of course. No? There is lobular hepatitis and interface hepatitis. Okay, particularly for hepatitis B infection, the hepatocytes have this ground glass appearance. No? For hepatitis C, there is formation of lymphoid follicles or aggregates, and there's also presence of fatty change. So again, this is the diagram showing us the morphology of chronic hepatitis. And so there are a lot of mononuclear infiltration in the portal tract region. There can be presence of fibrosis, bridging fibrosis, and we also have what we call interface hepatitis. We get to see inflammatory cells among the or in between liver cells. Then we have the ground glass appearance if we are dealing with hepatitis B. You get to see also the presence of apoptosis, and the presence of inflammatory infiltrates, mixed with the liver cells. And if you're dealing with hepatitis C, you can get to see presence of hepatic fatty change. These are actual slides. So this one shows us the ground glass appearance of hepatocytes, as we have noted. They are associated with hepatitis B infection. Whereas on our right, we have hepatitis C, as we can see, the aggregates, the lymphoid aggregates, or even the formation of mukhang mga lymphoid tissues, that would tell us that maybe what has caused this hepatitis is hepatitis C. Okay, on the other hand, we can also have, aside from hepatitis infection, There can be bacterial infection, parasitic infection, just like amoeba, no? Intamoeba histolytica, there can also be helmintic infection. So we have varied organisms that can affect the liver. There is also another state of a different type of hepatitis, which is autoimmune hepatitis. What is this? This one has a chronic progressive state. No, there is a genetic predisposition here. Okay, and since this is autoimmune, we get to see presence of autoantibodies. If you give immunosuppressing agents, no, they will respond to that. And as you have discussed, no, in your previous topics in pathology A, okay, for autoimmune problems, usually females ang involved, no? So there is predominance in females. Similar injury patterns with viral hepatitis, but there is a different time course for autoimmune hepatitis. Okay, so we get to see there. So we have here presence of lobular hepatitis with plasma cells, no, typical for this disease. So we have to differentiate it, of course, with um, viral hepatitis. Okay. Then we have the drug and toxin induced liver injury, no, which from time to time we encounter. Okay. It is classified as having this predictable hepatotoxins. We know the substances that are hepatotoxic, and if the patients are exposed to that particular hepatotoxic agent, this can happen, liver injury. There are times also idiosyncratic, just crop up, no, unpredictable at that. Okay, so patients will suffer liver injury for unusual, no, substances na kinoconsider na hepatotoxic, no. So effects would be either direct toxicity, no, the toxin or the drugs can directly affect or destroy the liver cells, or they can be converted, no, into an active toxin. There can also be an immune mechanism, no, that is involved here. Let us cite examples. We have acetaminophen, no, that leads to acute liver failure, and also alcohol. Chronic liver disease is expected to happen, no, in chronic alcoholism. No? So here, yung Rye syndrome, no, secondary to the intake of acetaminophen. Okay, we also have, no, we'll be discussing alcoholic liver disease. Okay, so alcoholic liver injury takes three forms. No? We have the steatosis or the fatty change. There can also be alcoholic hepatitis and steatofibrosis, a combination of um, fatty change with the presence of fibrosis as well. Okay, so this is a diagram that shows us the fate, no, of those who are having chronic alcoholism. Okay, so to begin with, normal liver with an intake of alcohol, patient can go having fatty change or hepatitis, reversible siya, no? So, make fatty change, you moderate the alcohol intake or stop it. Same thing with hepatitis, no? They can revert back to the normal liver. However, if there is a continuous exposure, no, or repeated attack of hepatitis, no, this too can lead to the development of cirrhosis. There is um, fibrosis, and we can see grossly, you know, nodular lesions on the liver, pwedeng macronodular to begin with, and then later on, smaller nodules, the micronodular um, configuration, secondary to fibrosis. Okay, so this time it becomes irreversible. Okay, so we have here the presence of fatty change. As you can see, the spaces, no? Those are the area that there is fat vacuole formation. For bigger areas, there can be destruction of several cells joining together, forming seemingly a cystic, no, fat cyst or fat vacuole, smaller ones. And this is a special stain that accentuated the areas of fibrosis. So you can see the blue areas. No, these are the areas wherein fibrosis has set in. Okay, so steatofibrosis. We get to see presence as well of swelling and necrosis. You have enlarged um, liver cells and the presence of Mallory Denki, no, body. This is like this one, okay, Mallory Denk body in alcoholic hepatitis, okay, and presence of infiltrates, neutrophilic infiltrates at that, okay. So grossly, we get to see nodular surfaces of the liver. Microscopically, we get to see uh, the fibrosis in blue stain, and then you can see certain areas of regenerating hepatocytes, fatty change as well. So this is the microscopic structures that we see in alcoholic liver disease. So with regards to pathogenesis, this happens if there is a daily intake of about 80 grams of alcohol or more. No? So this one has the risk for severe hepatic injury. The gender, more commonly in females, no, as compared to males. Pero maraming males ang makikita natin kasi mas maraming chronic alcoholic males. No? Ethnic and genetic differences are also factors. And the presence of comorbid conditions like kung merong iron overload or infection, then this would accentuate, together with alcoholism, this would accentuate the liver destruction. So what are the effects of alcohol? There are changes in lipid metabolism secondary to that. There is a decreased export of lipoproteins and mediated, no, mga reactive oxygen species induced cell injury, is observed here. Next, we have metabolic liver disease. Okay, so with metabolic liver disease, this is actually non-alcoholic fatty liver disease. No, there is increased risk for hepatocellular carcinoma, even without significant scarring. If you go back to alcoholic liver condition, no, the endpoint is cirrhosis. But this one, non-alcoholic fatty liver disease, even without significant scarring, this can lead to hepatocellular carcinoma. In alcoholic liver cirrhosis, it leads as well to hepatocellular carcinoma. Now, this is associated with insulin resistance, steatosis, as well as oxidative injury. So this is the flow that we can observe here. A patient having non-alcoholic fatty liver disease, there can be isolated fatty liver. Okay, that will be fine. However, if they go into non-alcoholic steatohepatitis, this can progress into cirrhosis, but there are instances that directly, in the absence of cirrhosis, patient will have hepatocellular carcinoma. So On this pathway, um, NASH cirrhosis, no, can be decompensation that would happen in the patient, or it can lead to hepatocellular carcinoma. We have other conditions like hemochromatosis, Wilson disease, and alpha-1 antitrypsin deficiency. Okay, so this is non-alcoholic fatty liver disease. You get to see the fat vacuole and fat cyst formation. There might be presence of um, fibrosis. Okay, however, what we get to see as well is, as I mentioned earlier, in the absence of cirrhosis, no, patients with non-alcoholic fatty liver disease have risk of developing hepatocellular carcinoma. Okay, we go now to the cholestatic diseases. Okay, cholestasis. Let's look at the function of the bile. So it is responsible for the emulsification of dietary fat, the ones that we take in. And it's also part and parcel of the elimination of bilirubin, the excess cholesterol, um, other xenobiotics, and other waste products. So yan ang role ng bile. Okay, so how is that? Jaundice results from if there's overproduction of bilirubin in cases of hepatitis, and of course in the presence of obstruction of the bile flow. So patient will be manifesting with jaundice eventually. Okay, so this is the process of bilirubin metabolism and elimination. So we have here, of course, the heme degradation, okay, and then there is involvement of the the enzyme oxygenase, okay, and then we also have presence of this complex, bilirubin albumin complex, with the help of reductase. Okay, conjugation happens in the liver, and the conjugation leads to the production of urobilinogen. So this is the process, degradation of heme, and then this one is taken care of by the mononuclear phagocytic system with the involvement of these enzymes, and then taken into the liver, okay, and then there's going to be conjugation process inside that. Tapos, the products will be, of course, released and then can be excreted as urobilinogen, okay, in the GIT. Okay, so for unconjugated bilirubin, this is said to be insoluble in water. So it forms a complex with albumin. They need the albumin. They cannot be excreted in urine, and unbound unconjugated bilirubin can diffuse into the tissues. So that's going to be a problem if there is a high level of this one, and not all of them can be bound to albumin. They can get into tissues, particularly the brain. This is the one responsible for the kernicterus. Okay, toxic injury happens. Kernicterus will have manifestations. Whereas conjugated bilirubin, this is water soluble. It is non-toxic. It is loosely bound to albumin, and the excess of which is excreted in the urine. Presence of cholestasis is due to impaired bile formation and bile flow. What happens there is that the bile pigment is accumulated in the hepatic parenchyma. So we get to see those greenish substances when we are looking at a biopsy of the liver. This is due to extra or intrahepatic obstruction, or there might be defects in the bile secretions. Okay. Other conditions, including cholestasis of sepsis, in the presence of septic condition, primary hepatolithiasis. Lithiasis is stone formation. We also have neonatal cholestasis. This is due to cholangiopathies like biliary atresia, as well as neonatal hepatitis. Okay, they also have autoimmune cholangiopathies, just like in the liver. No? So autoimmune cholangiopathies could be in the form of primary biliary cirrhosis and primary sclerosing cholangitis, PBC and PSC. No? So with PBC, this is a non-suppurative. So ibig sabihin, hindi siya yung neutrophilic infiltration. No? So there is inflammatory destruction of the small and medium-sized intrahepatic ducts. Okay, we get to demonstrate the presence of anti-mitochondrial antibodies in this condition. Whereas PSC, there is inflammation and obliterative fibrosis of intrahepatic and extrahepatic bile ducts, and then yung preserved segments will have dilatation. If you go to another condition in the GIP, I forgot the term for that. There is defect in the neural elements in the intestine. Hirschsprung's disease. There is affection or involvement of a certain area of the GIT, the colon, specifically the unaffected area will be dilated because of that constriction. So the same thing holds true here. So may fibrosis, smaller and lumen. So the other areas that are not involved, there is dilatation of that one. Okay. We also have structural anomalies of the biliary tree. Okay. So what are these? Presence of colodocal cysts. So merong congenital dilatation of the common bile duct. Meron ding fibrolipocystic disease, which are heterogeneous in character. We also have circulatory disorders. So we have this figure showing us the different forms of clinical manifestations of hepatic circulatory disorder. So kung involved this one, impaired blood inflow, presence of portal vein obstruction, intra or extrahepatic thrombosis, and a manifestation, we can observe esophageal varices in patients, enlargement of the spleen, intestinal congestion. Pagka intrahepatic blood flow naman, we get to see presence of cirrhosis and sinusoid occlusion. So patient will be manifesting with cirrhotic ascites, varices, hepatomegaly, and then of course elevation of liver enzymes, aminotransferases. Hepatic vein flow obstruction, so pag merong hepatic vein thrombosis, okay, in that Biliary syndrome, for example, or sinusoidal obstructive syndrome, same, we can observe ascites, hepatomegaly with abdominal pain, and elevation of aminotransferases with jaundice. Okay, so we have a common condition known as passive congestion and centrilobular necrosis. So we commonly see this in pre-terminal condition before the patient dies. There is ischemia of the different organ system, and that would include the liver. This would lead to passive congestion and centrilobular necrosis. Basically because of hypoperfusion, as I have mentioned, retrograde congestion, they call it also nutmeg liver, cardiac sclerosis, because a lot of times this is associated with congestive heart failure. So morphologically, this is what we see in the gross examination of the liver. So there is congestion, nutmeg configuration, grossly nutmeg, and then we have microscopic findings, congestion as well as not so prominent here, but we can get to see presence of necrosis, particularly in the area of the central vein, which is farthest from the blood supply of the liver. Okay, so we have here another topic in the form of organ or stem cell transplant complication. So sa liver, kung massive destruction, so what we can do is to do organ transplantation or newer modalities, stem cell transplantation, but we don't expect 100% success rate. There can be complications associated with it. If we go back, kung hindi siya massively destroyed ang liver, we know that liver cells are stable cells. If a certain part is destroyed, the remaining liver cells can cope to replace it with new liver cells. So that's the characteristic of liver. However, if the destruction or the insult is irreversible, then there's no way for this liver to be replaced with new ones, new liver cells. So the possible management would be organ transplantation or stem cell transplantation. So the problem there that we encounter is graft versus host disease. So what we do is most of the time you look for a compatible donor. However, as I've mentioned, it's not 100% success rate. So there can be a graft versus host disease or liver graft rejection. Okay. We also have instances that we encounter hepatic diseases in pregnant women. You've heard of preeclampsia. So patients are manifesting with maternal hypertension. Clinically, if you look at the urine of the patient, they would show proteinuria. Physical examination would show as peripheral edema, as well as coagulation abnormalities in this particular syndrome. Okay. Eclampsia, is a more severe condition, because this time, aside from the preeclampsia symptoms, patients have hyperreflection and convulsions, and this becomes life-threatening, not just for the baby but also for the mother. Okay, so most of the time, dito pa lang sa stage na to, the mother is already admitted to the hospital for monitoring as well as management. Okay, so this is the one that could happen. There is massive injury, massive hemorrhagic changes that could happen in the liver. Other conditions that are found in the liver, acute fatty liver pregnancy, as well as intrahepatic cholestasis. Okay, we go now to the discussion of the nodules and tumors that are found in the liver. Okay, so we can see nodular hyperplasia. So there is an increase in the number of cells here, in nodular hyperplasia. Or it can be a benign tumor in the form of hepatocellular adenomas, or malignant tumors in the form of hepatoblastoma, hepatocellular carcinoma, or otherwise known as hepatoma. There is also cholangiocarcinoma, which can be seen within the liver, or it can be outside the liver as well. So this is nodular hyperplasia, most probably gross examination, and then it must be seen microscopically for us to conclude that this is just hyperplastic change. No? So as you can see there is increase in the number of liver structures, liver cells in nodular hyperplasia. Hemangioma, of course, we all know that this is a vascular channel tumor. There are increase in the number of blood vessels here. Okay, this can be so severe, even if it's a benign process. No, this can be so severe that it would derange the function of the liver, leading to the demise of certain patients. We had one patient before, very young at that, So biopsies done and it revealed something like this, Hindi naman siya mukhang malignant. But then there is massive involvement of the liver, with this one. And it has led to the death of the particular patient. Adenoma, there is this tumor, a circumscribed tumor that is found in the liver. Whenever a tumor is found, then a biopsy must be done. And if it turns out to be composed of benign cells like this one, then it's just an adenoma. It's a benign glandular tumor in the liver. Hepatoblastoma is the most common tumor found in early childhood. So you get to see larger cells, uh, like this one, as compared to this seemingly normal-looking liver cells. Hepatocellular carcinoma or hepatoma, this is the most common primary malignant tumor. This is found to be associated with different conditions like hepatitis B and hepatitis C infection. These are among the hepatitis viruses. So silang dalawa yung nakita na associated with the formation or the genesis of hepatocellular carcinoma. Exposure to toxin, aflatoxin, which is found in peanuts, and then of course chronic alcoholism. Okay, so the setting is the patient is having a chronic liver disease. It's not an overnight process development of this malignancy, but it is in the setting of a chronic liver disease. So this is the gross morphology. Again, there is a tumor here. Okay, needs to be biopsied and visualized microscopically. You get to see large cells with increased NC ratio, hyperchromatic nuclei. So these are malignant tumor cells. Okay, so can be in the form of mostly large cell changes, but we can also have small cell changes. Can be unifocal, just one part, okay, or pwede siya multifocal. So in the liver, remember that if we see a lot of nodular structures and they are found out to be having malignancy, microscopically, we have to differentiate it from metastatic liver malignancy, coming from other organs in the body, because the usual thing is if you see multiple lesions, most of the time it is a metastatic malignancy. But please be reminded that hepatocellular carcinoma can also have a multifocal, multifoci, okay, involvement of the liver as well. Pwede rin namang diffusely infiltrative sa buong liver yan, can be infiltrated by the malignant cells. Okay, so iba-iba ang kanilang involvement. But as I've mentioned, most of the time, pagka multiple lesions, most probably it's metastatic, but we cannot totally rule out the presence of hepatocellular carcinoma. So a biopsy must be done as well, of course. No? So the reason for the multifocality, I would think that it's because of intrahepatic metastasis. No? So it could be in the form of vascular or direct extension. No? The clinical manifestation is not really that characteristic. No? Serologically, we get to see half of the patients will be having increased alpha fetoprotein. So, pag merong liver mass, the clinician would be requesting for alpha fetoprotein. So, pag elevated yan, together with the liver mass, they would think of hepatocellular carcinoma. Okay? Imaging studies, of course, no, ultrasound, CT scan, and clinically, the death of patients with hepatocellular carcinoma can be secondary to cachexia, okay? Or there are times na merong gastrointestinal or esophageal bleeding, massive bleeding, leading to hypovolemic shock, okay? Liver failure or even rupture of tumor leading to hypovolemic shock as well, no? Kasi nagkakaroon sila ng massive bleeding, but not because of the rupture of esophageal varices, no, or GI varices, okay? The next malignancy is cholangiocarcinoma. This is noted to be the second most common primary malignant liver tumor. No? So it is a biliary tree malignancy. No, this come from bile ducts that are within the liver. As I've mentioned, pwede rin siya, it can occur outside the liver. No, so cholangiocarcinoma can be intrahepatic or extrahepatic, which is known as the cracked skin tumor. So you see here involvement of the liver, okay, those pale areas, and even here presence of cholangiocarcinoma. Microscopically, we see a lot of glandular structures, smaller glandular structures, okay, with surrounded by this fibrotic material, no? So yung ating tinatawag na desmoplastic feature is very prominent in cholangiocarcinoma. Okay, so other malignancies, it can be a combined hepatocellular carcinoma with cholangiocarcinoma. We had one case before. We did an autopsy and it turned out to be a combination of hepatocellular and cholangiocarcinoma. There can also be vascular channel tumors in the form of angiosarcoma, okay, and then there are also, as I've mentioned, more common, condition, more common than primary liver condition or primary liver carcinoma are metastatic malignancies, metastatic neoplasia. Okay, so we have here a table that shows us precursor lesions that leads to hepatocellular and cholangiocarcinoma. So I will leave this to you. Okay, so look into it. Okay, so the next tissue that we'll be looking at is the gallbladder. So this one is attached to the posterior region of the liver. Okay, so regarding the gallbladder, we have certain congenital anomalies, presence of cholelithiasis, cholecystitis, and of course, from time to time, we get to see carcinoma involving the gallbladder. Okay, so these are just example of cholelithiasis, massive at that. These are cholesterol stones. Okay, and then we have the pigment stones here. Okay, it can be just a single stone or several or as many as this one. No? So regarding chronic cholecystitis, there are three features that we can observe here. Also, the presence of fibrosis, presence of RA sinuses. So kung ito yung mucosal lining, there is outpouching of the mucosa, forming the seemingly glandular structures into the muscularis layer. No, these are not malignant. We have to look closely at the features of the cells lining it. No, they are benign. These are known as the Rokitansky-Ashcroft sinuses. No, and of course the inflammatory cells. No, that are seen here, mostly, of course, lymphocytic infiltration. Okay, so this is chronic cholecystitis. We can also have cases of acute, cholecystitis, where we get to see neutrophils, infiltration, or a combination of acute and chronic cholecystitis. Gallbladder carcinoma, this is the most common malignancy of extrahepatic biliary tract. No, so this is gross gallbladder. There is a large area here. I have seen few cases of incidental findings of gallbladder carcinoma, with small areas of involvement. Okay, so they were operated on primarily because of chronic cholecystitis as well as the presence of gallstone. But on sectioning of the gallbladder, it reveals areas of malignancies, and we get to see something like this. No? So if you will compare it with the Rokitansky-Ashcroft sinuses, of course you have uh, you will see these glandular structures that are lined by tumor cells with hyperchromatic nuclei, no, as well as the presence of mitotic figures of normal mitosis. No, they're quite different from the lining epithelium of the ones that we get to see in Rokitansky-Ashcroft sinuses, which are benign in character. All right, so that's the end of the lecture. So seemingly short. Again, as I have been mentioning to all the lectures that I've been doing, you have to read your book. You have to read a chapter of the liver uh, and use this as a guide. Okay, have a good day, everyone.